Hi, this is Dr. Zafran, and this is the second portion of the Ischemic Heart Disease lecture for the USMLE Step 2. I began with looking at ischemic heart disease in the initial lecture, and this one is going to talk more about ST elevation MI and the way we diagnose it, the way that we look at the symptomology, how the EKG is a pivotal factor, what the treatment regimen is in the acute and chronic setting, what anticoagulation is essential, and the diagnostic procedures that will be of utmost importance in diagnosing ischemic heart disease and ST elevation MI and getting the patient the care that they need at the right and appropriate times. Now, if you listen to my ischemic heart disease lecture, part 1, the Mona Lisa was in that lecture, and she made a presence, and she's making a presence again. And I used her image in this picture because you can look at her face and get an idea of what the symptomology is in patients who experience chest pain, who may in fact be having ST elevation MI. You look at her face, she's grimacing with pain, she's putting her fist to her chest. One of the characteristic or pathognomonic signs of ST elevation MI or chest pain that has to do with atherosclerotic disease. Oftentimes these patients complain of an elephant sitting on their chest, or just a very deep pressure that lasts for many minutes that can radiate to their arm, sometimes even to their jaw, to their shoulder. These are very characteristic, typical signs of patients who have ischemic heart disease. Now, we talked about supply versus demand. In patients who have atherosclerotic disease, they have plaque buildup inside the lumen of the vessel. And when that plaque ruptures, what you can get is a thrombus, and that thrombus can lead to the ultimate occlusion of the coronary artery vessel. When that happens and you have such a decrease in your supply, the perfusion to the myocardium is compromised, and that can lead to myocardial ischemia or myocardial infarction. Previously, I talked about demand ischemia in patients who have atherosclerotic disease who may not have any symptoms, but when they exert themselves by doing strenuous exercise, or they acutely become anemic or even hypotensive, that leads to a demand ischemia or a stable angina, and that also can lead to myocardial infarction. Okay, so try to keep this image of the Mona Lisa in your mind, and when you're trying to remember and recall the symptomology of ischemic heart disease. Now, looking at this image, you see on the left an image of a vessel that has no atherosclerosis, and a vessel on the right that has lipid deposits or atheromas. And it's when these rupture that you can get the thrombus, as I mentioned previously. So an ST elevation is an ST elevation MI is a type of heart attack that can be defined as the development of a full thickness cardiac muscle damage. And how does that happen? Well, that happens from an acute interruption of blood supply to that part of the heart. This is where I can initially talk a little bit about how the coronary arteries, each as individuals, lead to perfusion to certain sections of the heart. You can almost look at it as like a grid. And what's beautiful and profound is that we have tools such as the 12-lead EKG that can give us almost like a portal or an understanding of what coronary vessels are perfusing which part of the heart. And when you have EKG changes like ST elevation or ST depression or hyperacute T waves, depending on which leads you're looking at, can give you a really good understanding of what the underlying pathology perhaps might be. So you're looking at this image, and in your mind you're understanding that the atherosclerosis can rupture, lead to the thrombus, and that thrombus leading to occlusion, where you get poor perfusion to that particular aspect of the cardiac tissue and muscle, then that can lead to a myocardial infarction. Let's look at this a little bit closely in 3 dimensions. Okay, here you have a coronary artery vessel, and let's go ahead and draw on here so that we get a better understanding of what we're dealing with. And this is to emphasize the point home. So here you look at the walls of the vessel, right? And you can see the atheromatous plaques growing and growing, right? And you can see that here. What you can also see is this thrombus that's been formed as a result of the rupture from the plaque right there. And that thrombus has now led to the occlusion of the coronary artery. We don't know which coronary artery this is, but if we did, we would have a better idea looking at the EKG as to what part of the myocardium might be compromised. Now that we have this occlusion here, you're seeing that it's very difficult for any of these red blood cells to get past. And as a result, you get poor oxygenation and poor perfusion, and then ultimately lead to compromise of the myocardial tissue. Okay? Let's go ahead and proceed. So let's look at the meat and potatoes of what we're going to be discussing now. With ST elevation MI, we're going to look at the symptomology, right? The symptoms that are experienced by patients who have an ST elevation MI, what kind of EKG changes you'll see on a 12-lead EKG, and the corresponding anatomy that corresponds to it, the management for acute ST elevation MI, and how that differentiates from the chronic management, what the timeline is when looking at your EKG, and understanding that the EKG changes may be in a very acute setting where it may be just moments or hours from the initial event, and what kind of changes in the EKG you'd find, versus during the lifetime of the patient, what kind of changes you would see in the electrocardiogram that will stay persistent, perhaps until the patient passes away of old age. And then the treatment. And the treatment, the important thing about the treatment is understanding what the treatment is, but also the time sensitivity within the treatment context. Okay? I have a snapshot here of the 2013 ACCF AHA guidelines for the management of ST elevation MI, and I want you to know that the information that we get from these guidelines is through many clinical trials, and those clinical trials give us guidelines to help give us a compass on how to clinically treat these patients. Now, you're going to look at each patient individually and separately, but having these guidelines, A, helps us for the exam for step 2, because they're going to ask you questions based on the standard of care, and the standard of care is based on the guidelines that you can see and all of the multiple tests and clinical trials that have been done. And we're going to try to bring all of that together so that you can, A, get the best score possible on this section and get the answers correct, but also as clinicians to be able to take care of your patients in the best manner possible. Alright, so with ST elevation MI, the first thing that we want to look at are the symptoms. We mentioned the chest pain that's consistent with ACS, pain radiating to the arm, shoulder, and jaw. You put that in line with the EKG changes. You can see a lot of different things on the EKG. You can see left bundle branch blocks. You can see ST elevation in greater than or equal to 2 millimeters in 2 contiguous leads, or even a persistent ST elevation greater than or equal to 1 millimeter in 2 contiguous leads. Again, we're relying on the EKG as our initial assessment to understand the underlying anatomy and figure out one of the pieces to the puzzle as to where the underlying pathology is. Now, here we're looking at this image again, and coincidentally, the answer to the acute treatment lies within this image, or actually within her name. Mona is the mnemonic that we use to understand the acute treatment for ST elevation MI. And M stands for morphine. And the morphine helps with ischemic pain, but it also will help decrease pulmonary edema in the setting of congestive heart failure with some of these patients. You want to have cardiac monitoring on these patients, continuous EKG lead monitoring, so as to see any dynamic changes that are occurring in real time. N is for nitroglycerin, and nitroglycerin will cause vasodilation. It will also help distinguish and differentiate between unstable angina and stable angina. Beta blockers are very useful in these patients, actually decrease mortality. And common examples of beta blockers are metoprolol, any kind of medications that end with OLOL. Those are not LOL, but OLOL. Those are going to be your beta blockers, and those decrease mortality, as does aspirin. And we'll look at decreasing mortality and the treatments that do that later on in this lecture as well. Aspirin being an anticoagulation, you want to decrease the risk of any kind of thrombi that can worsen the cardiac perfusion. All right, folks. So ST elevation MI and EKG, they're going to go hand in hand because the ST elevation, where do we even see the ST elevation? We see it on the EKG. So this is a really convenient and nice chart to help ingrain into your mind. It's color coordinated so that you can try to memorize it and understand it. But the underlying thing that you want to know here is that the leads and the lead placement and the changes, the dynamic changes that you find in the EKG are going to correspond with the coronary anatomy that's leading to that particular myocardial space. So in this case, if we look at the green, you'll see that leads 1, AVL, leads 5, and V6 correspond with the lateral leads. And the lateral leads are going to show you the inferior surface of the diaphragmatic surface of the heart. And the perfusion, the coronary artery that corresponds to that is occluded, that's leading to those changes, is going to be the right coronary artery. All right? So let that sink in for a second. Okay, there was your second. Now let's look at your inferior leads. So 2, 3, and AVF. That will correspond. I made an error. So let me go back. I want you guys to erase what I just said and think about this again. The inferior leads, okay, leads 2, 3, and AVF. 2, 3, and AVF. Those correspond with the inferior surface of the diaphragmatic surface of the heart, and that is perfused by the right coronary artery. And that's why I have my notes so that I can double check myself. Okay? Your lateral leads are 1, AVL, V5, and V6. And those are going to correspond with the lateral wall of the left ventricle. And the lateral wall of the left ventricle gets its perfusion from the left anterior descending artery or the circumflex. Okay? So I just want to make sure that that's clarified. Listen to the lecture again and make sure that you understand the difference between those two. The septal leads are V1 and V2, and that's going to correspond to potentially a posterior infarction with perfusion coming from the posterior descending artery. And last but not least, when you look at your anterior leads being V3 and V4, you're looking at the anterior wall of the right and left ventricles, and that's going to be perfused by the left anterior descending artery. All right? It's a lot to take in, but you're going to be able to rewind and look through this again multiple times. This is an easy question for them to ask you because it's a secondary and tertiary level question. They can give you a patient complaining of chest pain who had an EKG done and ended up having ST elevation in leads 2, 3, and AVF. So if you see that, you automatically know that, okay, we're dealing with the inferior surface of the heart here, and if we're dealing with the inferior, they could skip and ask you what is the coronary artery that's likely leading to the poor perfusion of this area that's leading to dynamic changes, and you would answer correctly the right coronary artery. And you'd be able to do that and extrapolate the knowledge for any of these other leads. Okay? All right. So As we continue our EKG analysis, I mentioned previously that depending on the time frame, you may see different things on the EKG that correspond with changes, right? Changes in your T waves, changes in the longevity. So it's based on time and what you're seeing on the EKG. So even within a few hours, up to 24 hours, you perhaps will see hyperacute T waves. As you get from even up to 2 weeks, you could still perhaps see ST elevation. So when you're looking at EKGs, what you want to do if you have a patient who's been known to the hospital or they're coming with medical records is you want to compare the EKG that you're taking right now with an EKG prior to this time. It could be 1 day, it could be 1 year, and you want to see if there are any changes between the two. Q wave changes can occur anywhere from 1 day to the entire life of the patient, as with T wave inversions, more of a chronic thing that you could see, even acute or chronic, within 24 hours leading up to years. All right, guys, so now we've gotten through the EKG portion of the lecture. Now it's time to talk about what kind of interventions are absolutely necessary for patients who have an ST elevation MI and what kind of time-sensitive treatments that we want to do. So we've been talking a lot about perfusion, right? And what we want to do is we want to establish reperfusion in a patient who has their blood flow compromised. And one of the gold standards of actually doing that is this procedure called percutaneous coronary intervention, otherwise known as PCI. And in a nutshell, what it is it's a procedure that is used to open blocked coronary arteries, and it restores blood flow. That's as simple as it gets, right? But when we look at it in terms of anatomy, what exactly are we doing here? I'm a visual learner, and I think a lot of people are visual learners. As visual learners, I think looking at this from a 3D perspective will help us understand and etch it into our brain as to what's going on. So this guy is laying on the table, and this catheter, this blue catheter, is going through the iliacs, right, the right external iliac artery, and it's the interventional cardiologist or the interventionalist is threading that catheter through the arterial system, going up the descending aorta, okay, and we'll flip him over. We'll continue to go up, and you'll see that this catheter, if I slow it down or make it smaller, you can see the catheter going through the aortic arch there. So what we're doing with this cardiac catheterization is we're using the arterial system through the aorta and being able to access the coronary arteries. And so this procedure is both diagnostic and therapeutic. Diagnostic in the sense that we're able to isolate the location of where you have poor perfusion in the coronary arteries. And it can be therapeutic in the sense that you can place stents through this catheter. You can use the balloon that's attached to it to push away the atherosclerotic thrombi or plaques to allow reperfusion. And if you're unable to do either of those, then you know that you can find which vessels are occluded and bypass them through surgical means, which would be a coronary artery bypass graft. Okay, so hopefully this kind of a 3D image gives you a better understanding of what PCI is and how important it is. Now back to the presentation here, let's talk a little bit about the time frame that's necessary for PCI, because time is of the essence, folks. All right. If the procedure needs to be done, then the time that the patient arrives at the hospital, which we say door to balloon, right? The catheter has a balloon. That's the time that they are diagnosed with the ST elevation MI to the time of starting PCI. We want to keep that under 90 minutes. if at all possible. Even if that means transferring from one hospital to another, some hospitals are not capable of doing PCI, and as a result, patients will need to be rushed to a hospital that's capable of having that done. So like I said, it's best if it's done quickly. Why? Right? The evidence-based literature tells us that if it's done within 90 minutes, patients will do better and they will have decreased mortality. I also want to add the fact that it leads to decreased deaths in patients with MI and ST elevation MI within 12 hours as well. So there is time to get it done, but your optimal time frame of door to PCI is 90 minutes. All right. Again, to reiterate this point, if PCI is not available on site, you want to get your patient or the patient rapidly transferred to a center that does have the capabilities to do that. All right. In patients who present with symptoms for more than 2 to 3 hours, right? Remember, we wanted to get them in within 90 minutes. If we're getting to the 2 to 3 hour mark, we suggest that the patient gets transferred for PCI. If it's within 2 to 3 hours, before you do that, what you can do is start a medical-based therapy, which is called thrombolysis. And thrombolysis is done via different agents, one of them being TPA, which stands for tissue-type plasminogen activator, or retiplase is another one, and tenecteplase is another one. And tenecteplase is oftentimes given with a G2B3A inhibitor, and that allows bridging to get the patient to PCI, but to have some medication on board that allows for thrombolysis and getting the patient to the endpoint that they need sooner. If you're going to combine these medications, like the recommendations are, when you're trying to get the patient to PCI, you want to decrease the dose of the tenecteplase, and this is a little bit more advanced, but the reason being is that there's a risk for anticoagulation when you're giving blood thinners for a patient to bleed excessively. And what that does, that leads me to the next point and what the absolute contraindications of thrombolysis are and what the relative contraindications are. And we'll also actually talk about what the indications, why it's important that we give them, and how they actually work. So thrombolytics work by lysing the clots, right? Which makes sense. Lytic means to break apart, and that leads to increased perfusion, and that is particularly beneficial in patients who have had a myocardial infarction. I mentioned that we're concerned about bleeding and what the contraindications would be. So if a patient has intracranial hemorrhage, aortic dissection, any extensive underlying bleeding disorders, or facial and head trauma that could potentially lead to extensive bleeding, you want to avoid, absolutely avoid, these thrombolytic agents. Another good type of question where you have a patient who may have been involved in a traumatic car accident, had underlying risk factors for myocardial infarction, and the question will simply ask you, should this patient get thrombolytic therapy? And you would say no, because there's an absolute contraindication based on any of these absolute contraindications. Relative contraindications include ischemic stroke, severe hypertension, ulcer disease of the gut. You know, we've seen patients who bleed tremendously from ulcers in the gut. Oftentimes they're treated very well and they're not having any bleeding. So in those particular cases, you may get away with giving thrombolytics, and you also want to avoid it in patients who've had recent surgery within 3 weeks. So as we start closing up this lecture, I want to talk about decreasing mortality in patients with ST elevation MI, and then on my last slide we'll go and look at the EKG again because I want to reinforce the importance of the EKG. In patients who are not contraindicated, aspirin is an absolute must. It decreases mortality, helps with survival. Beta blockers, statins, and in extreme cases or in cases where you can't do PCI, it's just not working, or they have extensive more than 3 vessel disease after doing PCI, Doing a coronary artery bypass graft for 3 or more vessels has been shown to decrease mortality, or even one vessel like the left main, bypassing that has been shown to decrease mortality. So looking at this EKG, this is a normal EKG, but I want you to, have a look and see it's very explicitly labeled to the different, leads within, right? You can see 2, 3, and AVF, and understanding that the leads correspond with coronary anatomy, and if you can get that in your mind and visualize it and understand the correlations, you're going to be able to get some of the more difficult questions answered properly. And the difficult questions on the exam are the ones where they don't ask you things straightforward. They give you clinical symptoms, they'll give you an EKG, and then they'll ask you, well, what is the anatomy? What coronary vessel corresponds to these? And if you can get those, you circle the right answer, you move on, and you can focus on things that are a little bit more challenging. Let's go back to this. So, I conclude my presentation on ischemic heart disease with these.